actually grew up in Holland, so far away. Went to Holland Christian, and then went to Calvin undergraduate school, and then went to Iowa for medical school training, and then did my residency in orthopedic surgery in the Toledo area. Part of that was spent out in LA as well, and that's where I really got an interest in the anterior total hip, which we'll talk about a little bit as well, actually at Cedars-Sinai in Beverly Hills. That was a little bit of training in my residency, and then I did a joint fellowship training just in hip and knee replacement surgery. So I specialize just in hip and knee replacements. That's basically all the surgery that I do anymore. And I did that training at the Anderson Clinic in Alexandria, Virginia, in the DC area. And then I've been here going on 7 years now. I do all my surgery basically at Holland Hospital now, and my office is located on the north side of town, just off Riley and 31 there. That's a little backdrop to where I grew up and came from. We're going to talk about hip and knee replacement surgery. We're also going to talk about just how you get arthritis, or how do you get to surgery, and what we can do non-operatively. We'll also talk about some modernization as far as surgery goes, and some of the newer techniques out, and what we're constantly always evolving and changing in the realm of surgery itself. But first off, we're going to talk about hip and knee arthritis. Basically, it's the #1 cause of debilitation or pain is hip and knee arthritis, and it's the wear and tear, the loss of the cartilage on the end of the bone. You can kind of see the numbers there. Actually, over 1 million surgeries of hip and knee replacement surgery was done last year in the United States, most of those being knees, but close to a third of those or more as hip replacements as well. And degenerative arthritis is the wear and tear, the loss of cartilage on the end of the bone, called osteoarthritis. There's also inflammatory arthritis, which is the rheumatoid type as well, but the major type is osteoarthritis. You can see there that osteoarthritis, again, is the wear and tear, or the cartilage loss of the brake pad tire tread wearing, and it occurs mostly in the large joints of the knee and the hip, because those are weight-bearing joints of the body. And then there's less common, the inflammatory and previous trauma or injury also can cause this. So you can see the rheumatoid, psoriatic, and juvenile arthritis there listed, but these are by far the less common and affect more of the smaller joints of the body than the hip and the knee of osteoarthritis. So arthritis, it's a pretty simple diagnosis. It's basically having an appointment in the office. We can get a two-dimensional x-ray right there in the office, and we can look at the hip joint and the knee joint and look at the spaces or the cartilage there, and we can see the loss of that space over time, or the loss of the cartilage. We usually have them doing this standing up to kind of look at that joint space while we're standing, not seated or lying down. Very few times do we need lab work. Lab work is more confirmatory for rheumatoid type or inflammatory arthritis, and sometimes MRI or 3D imagery is helpful to look at ligaments and tendons, or in the meniscus or labrum of the hip and the knee. And we also do injections, and we'll get into that a little bit more here as well. Talking about the knee, I don't know if I have a pointer on this. I do. So this is the thigh bone and the shin bone. You can see this nice space in between. That's represented in the black. That space is between the thigh bone and shin bone. You can see the space here on the outside, but you can see the loss of space on the inside. That loss of space is cartilage, and that's what an arthritic knee looks like on an x-ray. The knee is a more complex joint than the hip. The knee is made up of 3 compartments, and that's where we can talk about partial knee replacement versus total knee replacement, where hip replacement surgery is a ball and socket, and there's usually just one compartment to the knee or the hip itself, and we'll talk about that here, actually right here. So you can see here is a ball and socket of the hip joint. There's the ball, and there's the socket that comes around, and you can see the space here. You can see how there's no space here on the right, and that's the loss of that cartilage on the end of the bone. And hip pain is usually from arthritis, is usually groin or thigh pain that's in the front of the leg that can radiate down to the knee. It also can cause stiffness, similar symptoms in the knee as well, knee pain and stiffness of the knee as well, and it can also cause a limp that one can notice as well. So there's a lot of things, you know, I just was talking to my PA this morning in clinic, and he was telling me that I use this analogy a lot, but one is a train, and it's the last stop on the train is surgery, and what can we do for the hip and knee pain prior to surgery is kind of what we're talking about in these slides here. Exercises or keeping motion, this can kind of be kind of difficult, especially if we already have arthritis and dealing with a lot of pain. But keeping the motion in the knee in lower impact activities like swimming, cycling, elliptical type things to keep active and keep the motion of the hip and the knee. This also allows us to have weight reduction as well. Every pound that we lose is 3 to 4 pounds of pressure off the hip and the knee, so even a 10-pound weight loss can mean 30 to 40 pounds of pressure off the hip and the knee that can help with pain. So these are all very helpful things. Now I understand, obviously, with arthritis of the hip and knee, some of these can be difficult, but doing this in an aquatic setting or where we're walking laps in a pool, these types of environments can help manage the pain while we're being more active. Again, that's the weight management, kind of what I was alluding to with the weight loss, keeping active and keeping that down. Activity modification, these are the different low impact versus the high impact, the swimming and the walking versus the running. And the bike is cycling is a lot less impactful on the joints itself. Then we kind of turn to assisted devices to unload the joint itself, a cane, crutch, walker, to kind of help with stability over time, especially if the pain is becoming more disabling. We use braces and orthotics. Orthotics in the shoe can vary the alignment of, this is a tire rotation kind of thing. When we get the alignment off, we can have a different alignment of the hip and the knee and how we're walking. And these unloading braces or shoe orthotics can put pressures on different areas to lessen the load where it is more bone on bone and the cartilage is less. So bracing can be helpful in pain management with arthritis, but again, these are kind of to unload, to keep active at times. This again isn't going to build cartilage or slow cartilage loss. These are just trying to help with pain. And that's what we're dealing with. This is pain. Pain comes from the loss of cartilage on the end of the bone. The bone starts rubbing. That's where the nerve endings are, and it comes from pain, and that's why we're talking about it. And these are all things to try to manage pain. We have ice and heat. I get that question a lot. Ice is more to decrease inflammation and pain. Heat is more for circulation issues and cramping and that type of thing, and helps muscle aches. But typically for pain and inflammation and swelling, our preference towards ice overall. These are some therapies up here that can be used as well to manage pain. This is all talking about inflammatory markers around the hip and the knee itself. Glucosamine chondroitin is used quite a bit as a supplement. Again, this does not build cartilage or slow cartilage loss. This is just to help with inflammatory markers of the knee and the hip, and we can talk about different injections that we do, but to help inflammatory markers as well. Typically, patients have to be on these for a period of time, and it's not when you take it, oh, I feel a lot better. It's more when you go off of it, people are more, oh, that was doing a lot more than I thought it was going to do. So that's glucosamine chondroitin, and it comes in pill form. There's juice form. There's lots of different form and variation of that. You can also see some alternative medicines there with copper bands or braces or magnets. Acupuncture is also used to help manage pain, and then you can see different claims with vitamins and herbals. There's also diets that claim lower anti-inflammatory diets that can help reduce pain overall. Medications, you can see some of the over-the-counter ones. Acetaminophen or Tylenol is a pain reliever. It does not do anything for inflammation. It's not an anti-inflammatory like Advil, Motrin, Aleve. You can see there. The anti-inflammatory medicines are the ones that get at the root cause of the inflammation or pain from arthritis. Again, you have to watch that with your primary doc, to kind of, it can take effect on the stomach and kidney function long term. And if it's on this on a regular basis, it's something that sometimes laboratory or labs are good to follow up long term with. You can see some topical anti-inflammatory reducing pain activities there. There's also prescription strength anti-inflammatory topical creams and gels that we have too, and I think those are listed coming up. Again, the anti-inflammatory medicines, the NSAIDs listed up top there, the Clofenac patch and the lidocaine patch. There's also gels and creams that we can use. These are all prescription, working topically opposed to orally through pill form. And then narcotics are not really recommended for arthritis pain overall long term. We use those kind of briefly for post-surgical pain. for a brief period of time, but not used long-term for benefits of pain reduction in arthritis. Then we talk about different injections that we can do locally into the knee joint or the hip joint. There's cortisone injection. It's the biggest anti-inflammatory medicine there is, and we can put that locally into any arthritic joint. Typically, the larger the joint, the less painful the injection. So the knee is the largest joint in the body, so those injections are kind of like getting a flu shot in the front of the knee. Cortisone is kind of a potent one out there. It can last for several months, if not longer, depending on the degree of arthritis that you have. Now, this is not true for every patient. Is different how they respond to these. Some work and do these kind of on a regular basis. Some people, try it once and it worked for a while, but it didn't last. So hyaluronic acid is another one. Again, doesn't build cartilage, or these are kind of the lubricating injections. This does not build cartilage or slow cartilage loss down. It helps with inflammatory markers around the joint itself. And again, these are usually a series of injections. There's multiple different name brands, and typically insurance companies typically only choose one specific brand to cover. And again, these are a series of injections over time. We use these in the knee, not necessarily in the hip. And these injections of cortisone can be diagnostic, as a previous slide had suggested, meaning sometimes patients come in with hip area pain, but is that pain coming referred from the back or a nerve from the back, or is that truly coming from the hip joint itself? And we can localize that pain just to the joint of the hip by doing an injection there, and if it takes all your pain away, well, then the pain is coming from the hip, not referred from the back or a nerve from the back. So we can use these diagnostically to confirm the source of the pain itself. This is a good question. I get presented with this a lot. Well, when is it time for me to have surgery? Well, this is a multi kind of faceted question. Again, this is based on pain and quality of life and function. And so obviously there's risk to surgery, and that's the last step. Once we do that, there's no turning back to injections or pills or these types of things for that specific joint. So once we do surgery, we're taking on the risk of surgery and the risk of complications from surgery and the long-term effects of that implant. And so once we do that, there's, again, no option to turn back in time. Again, when's the right time for me? It's not your spouse or your friend saying, oh, you walk with a limp, you should get that fixed. It's more when it's time for you. And everybody's different with that. There can be different varying degrees of bone loss or severity of arthritis that can occur, and that's established with an x-ray, and that's where the surgeon can kind of go and talk with the patient to kind of see when it's a good time or not, when the injections are not becoming effective with the bracing, or the pills are not becoming effective to provide pain relief. Then that's something that we consider, the surgical options in the next step. And these are going to outline some, more conservative surgeries to more aggressive surgeries. Arthroscopic surgery is outpatient surgery. This is one illustrating the knee. There's also hip arthroscopy as well, which is a little bit more involved with recovery. But a knee arthroscopy is, you can see, typically it's illustrating 3 poke holes there through 3 instrumentations. Typically we do that with 2 now, and it's usually outpatient surgery. But this is more for meniscus tears or cartilage ring tears of the knee that we can go and trim out. But in this surgery, we can't put cartilage back on the end of the bone. So this is not treating arthritic long-term pain relief, because we can't put cartilage back on the end of the bone with an arthroscopy. An arthroscopy is, we have a shaver and a camera, and we can take pretty pictures of the cartilage loss, but we can't put cartilage back on. So this, used as a treatment for cartilage loss or arthritis pain, is typically not a great option long-term, but it can help, short-term pain relief with meniscus injuries and those types, or labral injuries of the hip. Well, this just jumps right into it. So this is a partial knee replacement surgery. Total knee replacement, again, the knee is made up of 3 compartments: the inside, outside, and under the kneecap. And so this slide here is talking about partial knee replacements. Partial knee replacements is where only a portion of the knee or the thigh bone and the shin bone is capped with a piece of metal and a plastic in between. You can see the outside here is preserved and under the kneecap is preserved. So this would be for one of those x-rays where the wear is just on the inside portion of the knee, is where we can get by with a partial knee replacement to resurface that and keep your ACL and PCL ligaments and keep the other compartments of the knee. Where a total knee replacement will resurface all 3 compartments, where a partial will only do one of those compartments. Advantages of partial knee replacements: the incision's a lot smaller than a total knee replacement. Typically overnight surgery, go home the next day type of thing. The recovery can be a lot quicker with rehab afterwards with partial knee replacement. But again, if you have multiple compartments full with arthritis or the cartilage loss, then we're looking more at a total knee replacement. This slide also is showing robotic assisted surgery. This is called a Mako robotic arm, seen right up and through here. And I've been doing this since January, where I've been doing Mako assisted or robotic assisted partial knee replacement surgery. What we do here, opposed to me or my eye making the cuts on the end of the bone to fit that implant precisely, what we do is get a CT or 3D image of that patient's knee or that specific knee to get the geometry of that knee specific. And then what we do at the time of surgery, we upload that CT into a software device here where we can map the implant on the end of the bone, and we can map the sizing and the position of this to the degree of 1/4 of a millimeter. And then what we do is at the time of surgery, I put a couple sensors on the knee itself, and we take it through a range of motion, and I can confirm with the software on what I'm seeing before I even make a cut. And what happens is then this robotic arm will come in, and I guide it at the time of surgery to make these burr cuts to remove only the bone that the implant will remain in. And then so it'll get a lot more precise implementation and a lot more feedback on the range of motion at the end of the surgery itself. So we've been doing that since January. Here is total knee. We'll be doing this here in July. We'll be the first in this side of the state to be doing total knee replacements through a Mako assisted arm, where the arm is now the saw blade and coming in and making those precision cuts on the end of the bone to place the implant specific, custom to the size of the patient themselves. This is a total knee application, again with all 3 surfaces here covered with the metal and the piece of plastic here going across the whole shin bone, where all 3 compartments now have the resurface, not just the portion of it with the partial. Total hip replacement. Again, we have the Mako assisted device available for hip replacements as well. However, in hip replacement surgery, it's only one compartment. It's a lot simpler of a joint, just that one ball. It's like a ball and hitch, where we go in and we remove a portion of that ball, and then we place a stem down the femoral or thigh bone here, and then we place a cup, and then there's a ball, and there's a plastic liner. That's what becomes your new brake pad tire tread, and that's what carpentry work of total hip replacement. Now, there's lots of different approaches to hip replacement, where in knee replacement, I didn't talk about the approaches. The approaches to the knee, typically, and I try to walk by here, but in the knee replacement, the approach, meaning the incision where we make the cut to get into the knee, mainly through the front door on the knee. There's no real side incisions or there's no back incisions because the arteries and nerves are in the back of the knee. That's what we want to avoid. And basically with knee replacement, partial or total, we are going through that front. There's not a lot of different doors to go through. With a hip replacement, the approaches can vary. We can kind of go through the front, meaning here, versus the side or the seam or more the buttock area in the back. And those are the 3 main approaches into the hip. And we have a lot of variability in those and what we can do the hip replacement, the carpentry work of hip replacement, and where we make the incision. Why that matters in hip replacement surgery is because if you make an incision more to the side or posterior to the butt, we're cutting through the biggest muscles in your body in order to do the carpentry work of hip replacement surgery, the glute muscles that we have to get through in order to get to the hip joint itself. so this is called an anterior approach, where we're going through the front. Well, there's muscles in the front of the leg as well, but they're more band-like. They're not the big bulky muscles of the glute muscles. And through an anterior approach, we can go work between the muscles, part them like a curtain, do the carpentry work of hip, and when we're done, the muscles fall back into place, and there's just suturing of the skin. So there's a lot less pain and a lot quicker recovery going through an anterior total hip replacement through a traditional posterior through the side. Most all my hip replacements that I do is through the anterior approach, through this front approach, and we can talk a little bit about the differences, further on here. But that's the main thing with hip replacements, that we're placing this through a different window, so to speak, where the knee, there's only one window that we're talking about. This summarizes kind of what I was saying, over 1 million hip replacement and knee replacement surgeries are done, and these are they're not linearly going up, they're exponentially going up. As the patient population increases in age, arthritis is not going away, and these surgeries are not going away, and these are continually to increase. Basically, this slide summarizes. I'll have some work to do ahead of me. I'm not going to slow down by any means of the imagination anytime soon, because these numbers are going up exponentially. Here's the number of primary hip and knee replacements done in 2010 in the this is just in the United States. You can see this over doubling in 10 years, and then doubling again in the next 10 years after that. This is just a slide. Actually, living in the state of Michigan, we are the only state in the country that has its own registry, joint registry, where the majority of all hip and knee cases are captured, and we follow outcomes of, through every complication, and we use all this data to continually modify and make our outcomes better. In living in the state of Michigan, we are only the state in the country to have a joint registry that we can look at all the numbers and the data collected from joint patients here. That marquee is a collaborative of all. You can see the number of cases that were collected in marquee. This is year data of last year, and you can see 40,000 hip and knee replacement surgeries done in the state of Michigan that were collected. Holland Hospital doing 807 of those. For the size hospital it stands out in the numbers across the board. You can see the length of stay, and these numbers are compared to the collaborative, which I think actually the collaborative from national standards is very, very good. And so you can see the length of stay is overnight. This is just meaning 1.4 days versus a total of 2.2 on average. And you can see the numbers there across the board, discharged to home. These are not just my numbers. These are all numbers at Holland Hospital compared to the collaborative against all joint replacements in the state itself. You can see transfusion rate, needing blood transfusion of where that is compared to the collaborative. And you can also see 90-day readmissions for any kind of thing surrounding hip and knee replacement surgery. This is just talking about the Joint Replacement Center and the program that we have established at Holland Hospital. We have a very involved floor that is specific to just hip and knee replacement patients, where their own private suite rooms for hip and knee replacement and dedicated physical therapists. So we have these books that outline a full program, whether it's hip or knee, outlining the benefits there. Christy Dennett is the joint coordinator. She's standing in the back, and her card is available there. This is a picture of one of the floor shots up on the unit. Again, typically on average, my anterior total hip replacements, if we have surgery that morning, they're up walking around that evening and basically staying that night and having a therapy session in the morning and leaving after that morning session. With knee replacement, partials are staying usually overnight, go home the next day. With total knee replacements, they may stay 2 nights and go home the 3rd day. And majority of all patients are going home, not needing a nursing home or rehab facility afterwards. And they're walking very limited, assisted devices with a hip. We may need a cane for a week or two for stability purposes. A knee may be similar aligns with a cane or a walker for stability purposes afterwards. And advising that booklet that we talked about has a home exercise program as well outlined in it, which patients are very well versed before the surgery even takes place. This is talking about some recovery things. Usually I see patients back and looking at their incisions at 2 weeks, and then I see them back at 6 weeks. And then, talking about driving and when they can do different things based on a hip or the knee. There's definitely a lot of awards that have been collected over the years. I think I joined the program back in 2010, and these are awards that have collected over the years at Holland with their numbers in excellence in joint replacement surgery.